Good morning. I didn't hear anything. Okay, that's much better. All right, well, welcome to the CMS 2018 Medicare Advantage and Prescription Drug Plan Fall Conference and Webcast. My name is Stacy Plizga, and this is Kay Rabel, and we will be moderating the conference for you today. This morning, we are gathered here in the CMS Central Office Auditorium in Baltimore, Maryland, where it is very hot and the webcast is originating from. We have a number of CMS subject matter experts and sponsors who will be providing important new information on Medicare Advantage and prescription drug plan to prescription drug plan sponsoring organizations, CMS staff, and other CMS partners. We would like to recognize all of our guests that are here today, both our in-house guests, thank you for being here, and also those who are viewing on the webcast. We are so excited to have all of you here today, and thank you for joining us.
Okay, before we get started, I would like to review a few logistic items that may be helpful to you throughout the day, which includes materials. The conference materials to enhance your experience are available on the CTO website and include the Fall Conference Guide, which lists speaker bios and agenda topics, speaker presentations, which are in an electronic format so that you can download them, as well as participant instructions to assist you with connecting to our polling software. In addition, we will also provide a participant survey instructions. The participant survey instructions include web links as well as QR codes for our Ask CMS Questions Live survey, the post-conference participant survey, and the CCB attendance survey that needs to be completed by September 24th in order to obtain CCB continuing education credits. To summarize, our conference materials include our conference guide, our speaker presentations, our participant instructions, as well as our participant survey instructions. These materials, once again, can be found on our CTO website listed on the screen. And if you have not done so, go ahead and log on to this site to obtain your presentation and materials to follow along with today's presenters. Next, if you encounter any technical difficulties, we do have staff available to assist you. Please use the email box, CTO Tech Support at cms.hhs.gov for any technical questions or concerns. Remember to optimize your streaming experience. Go ahead and plug into an Ethernet connection instead of Wi-Fi, and use Google Chrome instead of Internet Explorer to prevent any delays.
All right, the Medicare Advantage and Prescription Drug Plan Fall Conference and Webcast will feature interactive polling during the sessions and also for end-of-session evaluations to allow both our in-house guests and our virtual guests to participate throughout the event. There are a number of ways that you can participate. You can respond to polling questions utilizing your cell phone and sending a text message, or you can respond from any smartphone, tablet, or computer by visiting the Poll Everywhere website, which we will talk about shortly. If you would like to participate in the polling and the session evaluations, and we encourage everybody to do so, you must first join our session. So if you would like to do it utilizing your cell phone, please get that out, and we will do that together. So take out your cell phone and then select your text message screen. You're going to create a new text message, and then you're going to type 22333 into the recipient box. After that, you are going to type in CMS 2018 Fall into the message box. This is not case sensitive, but please do not put any spaces in between the letters or numbers. You will then send your message, and you will get a message back that says you have joined the CMS 2018 session. This will remain open for the entire day, so you do not need to do that again. If you had any difficulty with that, please see one of our CTO staff members and we will be happy to help you. All right, to enter your response, each time that a poll is conducted, you will simply type in the letter that corresponds with your answer and then send your message. To respond to the end of session evaluation questions, which are different from the polling questions that the presenters may ask you, when prompted by the moderator, you're going to enter the letter A into the message box on your phone in response to the statement, "I would like to evaluate this session." And then you will send your response. You will then receive a text message back that says, "Hello, please evaluate my session," and it will give you a link. If you click on that link, it will take you to the Poll Everywhere site, and you will choose Start when presented with the questions. And then you are going to select your first answer and then click on Next, because you will get one question at a time. And then after the fourth question, you will go ahead and click Submit, and your responses will be submitted. If you would rather join Poll Everywhere via a computer, tablet, or smartphone using your web browser, you must first join our session again. And to do this, you are going to go to www.pollev.com/CMS 2018 Fall. Once you do that, you will be presented with a welcome page that tells you to please stand by. The polling questions will appear when the poll is activated. So you'll get a screen similar to the one that you see up there right now. To enter your responses into the web browser, simply click on your answer and your response will be entered. To respond to the end of session evaluation questions via web browser, when prompted by the moderator, again, you're going to go ahead and choose Yes in response to the question, "I would like to evaluate this session." You will then be presented with a link that will take you to the questions, and this appears in a green box at the top of the screen. Go ahead and click on that link. And when the next screen appears, you are going to choose Start Survey, and then you will be presented with the evaluation questions one at a time. When the next screen appears, choose Start Survey, and then select your answer, select Next, and then after the fourth question, again, you are going to click on Finish. So we're going to give this a try together. Hopefully everybody was able to connect. Remember, you either need to text into CMS 2018 Fall or follow the web browser link. And it seems like we have a lot of people responding already to the question, which emoji best represents your morning? And the one we are missing today is the really hot emoji because it is brutal outside. So let's see how we're doing today. And if you notice, as you are putting in your answers, the percentage bars are changing to show how you guys are doing today. And it looks like most of us are happy today, so that is a very good thing. We will check back with you after lunch and to see how you are feeling then.
Okay, it's awesome that everyone is happy today, or most of us. So we look forward to everyone's participation in today's event. For our webcast participants, if you have any presentation-related question at any point, go ahead and go to the SurveyMonkey link or QR code, which is found in the participant survey instruction sheet posted on the CTO website. And go ahead and enter your contact information and questions there. We will either answer these questions today during the event, or they will be answered by our subject matter experts and posted to the CTO website at a later date. For our in-house participants, we ask that you address your questions using the microphone located in the center of the room. That way, all of the participants, in-house and remote, will have an opportunity to hear the question. If you have any technical questions about polling, please send your email to tclagholtz@provider-resources.com. And if you have a technical question regarding the conference or webcast, go ahead and send that to the CTO tech support at cms.hhs.gov. We really value your input, and we will also have a post-conference participant survey. We ask that you complete this either by following the link on the screen or utilizing the QR code, which is found on the cards on the table, or the participant survey instructions posted on the CTO website. To utilize your QR code with an iPhone, go ahead and open the camera, line up the QR code in the camera, and tap the pop-up window. If you'd like to utilize the QR code with an Android device, go ahead and open the Play Store, search for the QR code reader, tap Install, then Accept, open the QR code reader, and line up the QR code in the camera, and tap OK. For our in-house participants, we also have a photo backdrop experience. This is new this year to our program, and it is a CMS photo backdrop outside. If you would like to take a picture in front of the backdrop, take out your phone and see a staff member for assistance. Please note that if you have a CMS badge on you, you will need to remove it for the picture, okay? Also, the videos for the event today are not available for on-demand viewing until we receive final management approval. And once that is done, there will be a communication, and it will be sent to all of the registered participants about when those videos will be available. All right. Additionally, if you have any luggage, it can be placed in the back of the room. However, CMS is not responsible for it.
We are glad to have all of you here with us today. Our agenda today is packed with subject matter experts who are excited to share their knowledge and their expertise, so let's go ahead and get started. Kicking things off for us this morning with an update to CMS's activities focused on Medicare Advantage provider directories and the Medicare Communications and Marketing Guidelines from the Division of Surveillance, Compliance, and Marketing. Please help us welcome Jeremy Willard and Christine Reinhard.
Good morning. It's great to see so many familiar faces. Oops. Okay. So Christine and I will be talking about the MCMG today, and let's dive right into what we have for our agenda. We're going to start off by taking a brief look at the regulatory changes that really made the changes to the MCMG possible. We're then going to be taking a closer look at the MCMG itself, discussing what parts of it are the same, highlighting those notable changes, some of which are big, as you know, and then also reviewing some common questions and updates by section. And when I say updates by section, you'll be happy to hear that we're releasing an updated MCMG today. We were hoping to get it out last night. We had a couple of 508 snafus, but I'm getting thumbs up. It's out there now. So I shouldn't have said that because everybody's going to look at their phone now. But so it is out there. We will be issuing an HPMS email blast to let everyone know that it's out. And so we'll be touching on some of those changes. So as I go through today's presentation, you'll note that anything in a red font are things that we've changed in the MCMG. I wouldn't say anything major. The website review was probably a major change, but we did that a little earlier, thinking that it needed to be done earlier. So we will dive in and then conclude with a Q&A with regard to the MCMG. And then Christine is going to talk a little bit about provider directories as well, give an update on that. So changes to the regulation, this is by no means an all-inclusive list, but as you know, several months ago we released our regulation that had some pretty monumental changes to Subpart V that allowed us to kind of set the cornerstone for the changes to the MCMG and to marketing and communications in general. Some of the big heavy hitters, I would say 2260, and these are for 422 and 423. Marketing is redefined as a new term, and so we've taken marketing, which used to be everything, and we've narrowed that down to a much smaller subset of a new concept, which we added, which is communications. So now communications is really any material or activity that interfaces with the beneficiary, marketing becoming a subset of it. Under 2262, small letter D, we have the authority to review communication materials. And then 2268, there are many parts of 2268 that are the same from the previous regulation under Subpart V. We've added things like the OEP marketing, or prohibition of marketing during the OEP. But then we've split those requirements under the old 2268 for those that we felt as though we wanted to apply to all materials or communications, and then the subset of those requirements falling under marketing. So we kind of reallocated those under an A and a B based on how we wanted them to apply to materials. And then finally, outside of Subpart V, we've made changes to 422.111 that allows us to allow you for electronic delivery. So now let's take a look at the Medicare Communications and Marketing Guidelines. Christine would be very upset if I didn't say that internally we've been affectionately referring to this as the MCMG, because nothing in the government is ever great unless you have a super acronym to go with it. I have to say I'm a late adopter to this, so I typically just say MCMG, but if you want to be a part of the cool kids, you can definitely say MCMG. So what's inside the MCMG? And I had to include this very nerdy graphic of how I would imagine, a funny way of putting together the MCMG, where we have the reg going into this sausage grinder and we turn the handle and then out pops the MCMG. I really wish it was that easy. As you know, it's probably, it's not that easy. And that leads me to talk a little bit about the timing of the MCMG. We've received a number of questions on, can you get it out earlier? Can you please get it out earlier in the future? And that's certainly a goal of ours. It's always a goal of ours. However, given when the reg came out and when the reg was released, we found ourselves in this position where it was, we were kind of at a crossroads of, do we try to get the MCMG out when we did as soon as possible, or do we delay implementing some of these flexibilities? And we thought, while it's not perfect to send it out a little on the late side, it's better to get that information out to the industry so all of those flexibilities go into effect, rather than kind of delaying it and doing kind of what I would say an MCMG light and then moving more into some of the heavy hitters later in the year. So starting with Section 10, there's a lot of familiar requirements in Section 10. Anybody that's read the MMG would feel at home with Section 10, I would say. It outlines what entities fall under the scope of the MCMG's guidance. It also reiterates that plans are responsible for compliance, and this includes downstream entities. So this is all very familiar. A common question for Section 10, and this is kind of a funny way of saying it, but we have received a number of questions where those submitting the questions are saying, well, I noticed that X was in the old MMG and it's not in the MCMG. Does that mean that it's allowed or it's no longer allowed? And I would say a rule of thumb is if it's not in the MCMG, it's now allowed. We've really consolidated a lot. We've really backed away from some of our previous requirements. And so the MCMG replaces in whole the previous MMG and all the guidance that went with it. Now, turning from familiar to very unfamiliar, the communications and marketing definitions. As far as what's familiar in this section, absolutely nothing. So going from the regulation and all the changes under Subpart V, we've made a lot of changes to the definitions. And at their very high level, communications, as I said, pretty much anything or any activity that interfaces with a Medicare beneficiary. Marketing becoming a subset of communications, really with the intent to influence a beneficiary's decision about their health care coverage. And that's the way we positioned marketing as a subset. Now, diving in a little deeper to marketing, we look at this critical component of the MCMG and the regulation as a whole, and that's this two-pronged definition of marketing. And marketing is based on intent and content. And this is, in my mind, the most critical part of both the regulation as well as the MCMG. The intent of marketing is to draw beneficiaries' attention to a plan or plans, and it's also to influence an enrollment decision. And that influence goes or counts to those that are prospective members, as well as those that are existing members, and we call that retention marketing. Now, in addition to intent, we have the concept of content. And this means that marketing contains information about the plan's benefit structure, cost sharing, or measuring and ranking standards. In addition to that, we've created some exclusions under this part of the regulation. The materials that include the content but do not meet the described intent fall outside of the definition of marketing. So what do we mean by that? We create materials which are outlined in section 100.4, and Christine will be talking about that here a little later. And these are materials that CMS requires plans to have as a part of being in the program. Many of these materials are not really intended to drive an enrollment decision, to go into a plan or not into a plan. And so from a content standpoint, an EOC would be a great example. The EOC has content that would fall under marketing. So it's, there's benefit information, there's cost structure information. However, the intent of an EOC is not really to persuade somebody to enroll into a plan. You don't see an EOC plastered on the side of a bus or anything like that. That would be a really, really long bus. So this key concept that intent and content both must be present for something to become a marketing material is critical as you review and work in the MCMG. If it doesn't have the intent and content, then it's a communication material. Now, when we take that and we apply it to material designation, as I said in section 100.4, we have a pretty comprehensive list of all of those materials that a health plan has to have. And these are all the models that we create and we have to be issued based on certain scenarios. So we have the luxury of saying whether they are communications or marketing. Now, when it comes to materials that a plan creates, you're in the driver's seat for that. So you need to look at the regulation, look at the guidelines in the MCMG, and to consult with your account managers and/or marketing reviewers, as well as using other resources such as the Medicare marketing email box to determine whether a material that you create is marketing or it is communications. And based on that determination, that will determine what path it takes with regard to the guidance in the MCMG. Some common questions for Section 20. What communication materials must be submitted and/or reviewed? So as I said in Section 100.4, we outline the vast majority of materials that we require. I will say that we have additional guidance in this section, and Christine will probably be touching on that, where we say if something isn't specifically called out, a required material isn't specifically called out in Section 100.4, a plan can assume that it's a communication. That was another question that we received. So we tell you what's communication, what's marketing, and whether it needs to be submitted or not. Communication materials that need to be submitted to EOC comes to mind again. We also, lost my spot there. So that should give you kind of what you need to know with regard to the communications material. Now, for those materials that are communications that you create, they do not need to be submitted unless you hear from CMS otherwise. So anything that falls outside, as we have it now, anything that you create now outside of that list in 100.4 does not require submission if it's a communication material. There may be a case where if we receive a complaint or something like that, we may ask you to submit that into HPMS if we want to review something retrospectively. However, at this time, we have no list of materials that fall under communications that would be produced by the plan outside of what's in 100.4. Another question is, the definition of marketing specifically mentions MA plans twice, and that could be interpreted that it's very MA focused. And I apologize for slighting my Part D friends out there. And we have made an update to the MCMG that's posted today where it's a much more harmonious definition that includes everybody. Section 30 is general communication requirements. And again, if you think of communication and marketing being a subset of that, what we mean by communication requirements is that both marketing and communications have to follow these guidelines. This section is chock full of a lot of very familiar concepts. Anti-discrimination, standardization of plan name, requirements for non-English speaking populations and materials, prohibited terminology. listing of hours of operations, as well as the use of TTY numbers. These are all things that if you've been working in previous MMGs should be very familiar, and really from a policy standpoint have not changed. One thing that has changed is 30.7. So prohibited terminology, like I said, for the most part, prohibited terminology is very familiar. However, we have added some new guidelines specifically to what we refer to as look-alike dual SNPs. The agency's become more and more aware over the past year of plan offerings that mirror dual SNP plans but are not a dual SNP plan. They use ad copy that if you were to read it, you would assume they're a SNP. They make mentions to coordinating with the state and other things that are very confusing to beneficiaries. So to try to kind of stem that confusion, we've created some of these new guidelines that these plans that are not SNPs are not able to imply that the plan is designed specifically for SNPs and for dual eligibles. They cannot claim or infer that they have a relationship with a state unless that's the case, and I would say that of those that I've looked at, I haven't seen any relationship with a state. They also can't target marketing efforts exclusively to dual eligibles. And so one of the perks of being a dual SNP is that you are allowed to target the dual eligible population. It allows you to just focus strictly on dual eligibles. Outside of that, with a regular HMO or PPO product, you're unable to, or it's non-compliant, to just focus on a specific audience in a service area. That would be a cherry picking or a cherry picking like activity, and it's prohibited. A couple common questions for section 30. 30.5, which is, deals with TTY numbers. We received a question about are plans no longer allowed to differentiate the font size for television ads when it comes to posting the regular call center number and the TTY number. I could see why this was asked. In the previous MMG, we specifically called out the fact that that could take place. So in the update that I've been discussing, we have made a note in there that television ads may use a different font size for TTY numbers to kind of keep beneficiaries from being confused when these numbers are kind of being flashed and calling the wrong number. 30.8, are provider testimonials now allowed? So in the testimonial section, we did not have any guidance on whether provider testimonials were allowed. As you know, there was a prohibition on that in the past. In the MCMG, under the current rules, provider testimonials would be allowed. So now turning our attention from the wide, broad Section 30 into the more narrow Section 40, which only applies to marketing materials. Again, some familiar requirements in this section: nominal gifts, exclusion of meals, which is a regulatory requirement or a statutory requirement, marketing of star ratings, and the marketing of rewards and incentives. Some changes: 40.1, plan comparisons, and this is a major change from previous MMGs. Plans are now allowed to make direct comparisons to their competitors. Any comparison must be supported by fact, and I'll talk a little bit more about that as we go through the presentation. Materials that include plan comparisons are marketing. So anytime you make a plan comparison, anytime you're comparing yourself to your competitors, or I would say even the general landscape, that would be considered a marketing material based both on the MCMG as well as the regulation. And then finally, and this is a good rule of thumb, and I'll talk again a little bit more about this as we go through, such plan comparisons cannot be misleading and cannot be confusing to the beneficiary. That is something that we're paying very close attention to when it comes to using this sort of advertisement. So we want to be very careful that when doing comparisons, it's a clear message to the beneficiary and not in any way kind of leading them down a path that's not, not taking them to a non-factual place. Section 40.2, marketing through unsolicited contacts. Email may be used, and this is something that we've discussed in the past. So email is no longer considered an unsolicited contact. We now make email kind of analogous with good old-fashioned snail mail. And I think that's a sign of kind of how we've progressed over the years. I mean, when we first wrote Subpart V and the guidance that went with it, email was something kind of different than it is now, and now it's really taken the place of mail in many ways. So when plans are using email, you must provide an opt-out function, and I think that's pretty commonplace when it comes to email marketing. And then finally, this allowance of, or I should say, having email no longer being required in unsolicited contact, this does not extend to things like text messaging or other means of direct messaging through social media. I think of like Facebook Messenger and some other social media platforms that allow for direct messaging. We think of that more analogous with unsolicited phone calls. 40.3, speaking of unsolicited phone calls, this is and has been a prohibition. So we've had a longstanding prohibition that unsolicited phone calls are not allowed. That still remains true for the MCMG. However, we've provided a lot of additional guidance with regard to what can be done under the guise of planned business. And the best way to think of planned business is, that sort of conversation is not an unsolicited call. So this would be if you're a plan, let's say a standalone PDP plan, and you offer an MAPD, you'd be allowed to call those members and talk about the MAPD product. I would say from an agent broker standpoint, if you have clients that maybe you sold home insurance to or car insurance to, you have a relationship with that person. Calling them to talk about Medicare Advantage offering would not be considered unsolicited. This last sub-point here, disenrollment surveys. In the past, disenrollment surveys were allowed and continue to be allowed. However, we made a change in the MCMG that said that agents cannot conduct disenrollment surveys. And I have to tell you, when I wrote that section, and when I did so, I was thinking really through the lens of a plan and what a disenrollment survey looks like for a plan, and I thought to myself that that's something that I couldn't imagine an agent or broker doing. The MCMG gets published on July 20th, and then soon after that, I received a lot of phone calls from the agent broker community, and they said, wait a second, we do disenrollment-like surveys where we're not calling on behalf of the plan, but we may call a client and say, oh, why did you move from plan A to plan B? Or you left our agency, is there a reason behind that? To get more information so that they can better themselves in the future. And so I think we really saw the value in that. So we've updated, and as you can see it in red, in the re-release of the MCMG, we've updated it to make it clear that agents are allowed to do that. Whether it be an agent or a broker, or agent broker or a plan conducting these surveys, they cannot be used for marketing purposes. And calling someone under the guise of planned business can also not be used as a means of kind of getting around the 10-1 start of marketing. So if you're making a call today using planned business as your kind of path to calling that person, you cannot discuss things that would amount to marketing. So you can't talk about cost sharing and things like that. It's not an opportunity to kind of get an advantage over your competition. You can certainly do that after 10-1 though. 40.7 was another big one, and I'll be talking about this from a question standpoint as well. Prohibition of marketing during the OEP. And it's important to note that this comes from the 21st Century Cures Act. If you've ever read the Cures Act, and I'd like to meet the person that read the entire Cures Act because it's quite a long law. At the very bottom of it is this little blurb that was put in there that says you're not allowed to market during the OEP. We updated our guidelines under 2268B of Subpart V and said that plans may not knowingly target beneficiaries who are in the OEP. And there's been a lot of questions around this. I'll answer some of those as I get into the questions section. But it's important to note that during the OEP, you are allowed to do marketing. It's just you cannot specifically target those in the OEP or use language that's specifically calling out the OEP. So common questions for Section 40. The first, and this was one that we received very quickly when we issued the MCMG, is there a typo in Section 40.7? And I appreciate all of the eagle-eyed editors out there that brought this to our attention. And if you see that third bullet should actually be moved up to the second bullet to complete the sentence. And we've made that update in the re-release. 40.1, a question that goes with that, which is plan comparisons. What sort of documentation is CMS looking for? And a secondary question to that is, are there any restrictions on years or service areas? From a documentation standpoint, we really didn't want to be overly prescriptive here. I think documentation, either showing studies, anything that can prove the factual basis of such a comparison is the type of thing that we'd be looking for, but we wanted to have some flexibility with that. When it comes to restrictions on years as well as service areas, same thing holds true. We didn't want to have something very rigid to say like, well, if it's older than 3 years, you can't say it. Because I could personally think of an organization that may have been a 5-star plan for 5 years in a row, and we wouldn't want to limit them from only talking about the last 3 years. Same thing with service area. I could see a plan that has had, some stellar statistics or maybe been named by J.D. Power or something like that in a service area that they're currently in, and as they're moving into a new service area, touting the fact that, that track record, I could see that sort of thing taking place. The important thing, and I'll note it again, is it can't be confusing to the beneficiary and it must not be misleading. Those are the rules of thumb that you should use when you're creating these sorts of marketing materials. 40.7, which deals with the OEP, or prohibition of OEP marketing. Question was, we typically market to MMPs and SNPs. Is that still allowed? The answer is yes. You're certainly allowed to do that. And then 40.7, same OEP. How will CMS distinguish compliant versus non-compliant marketing during the OEP? And this is somewhat of a complicated question, I understand, but I tell you, if I boiled it down to its most simplest term, I would say, sit back and think about the types of marketing that you did last year during the same period of time. And odds are that would be allowed this year during the same period of time, because what you were doing last year when there was no such thing as an OEP would be the types of things that would be allowed this year. If your marketing department gets wind of this and they start saying, oh, we could do this and we can do that and maybe we can mention this and mention that, I think that's where you start to tread into some dangerous waters as far as compliance goes. So those are the types of things that we're looking at. We're looking at the content of the message, whether it's specifically mentioning OEP or an extra chance to pick another plan or to make another decision, as well as the intention. So if you're buying a list of only those that are in the OEP, that would certainly be an indication of kind of going down the wrong path. I want to say when it comes to the prohibition of marketing during the OEP, in reading the law, my takeaway is that Congress wanted to allow this as an opportunity for beneficiaries to make another plan choice should they need that, but not necessarily an opportunity for there to be a secondary marketing period. And I think if you think of it through that lens, you'll be in a safe place. Section 50, which is outreach activities. There's a lot of familiar requirements here. Marketing and sales events, both from the broad standpoint as well as personal marketing events. We've streamlined those sections quite a bit, but from the standpoint of policy, what's allowed, what's not allowed, really no substantive changes. Where we have made some changes is in 50.1, those being the educational events. And this was made possible, as I said, when marketing had a very broad definition and basically everything that went to a beneficiary was considered marketing, and there's a restriction on marketing at an educational event, it was very limited in what could be done and what could be said at a marketing event. Now that that definition is more focused, we are allowed to do more things at an educational event. Plans may include communication materials, so communication is not marketing. So any sort of communication materials or communication activities can take place at educational events. Plans may answer beneficiary questions, and I would go as far as to say that in answering beneficiary questions, the content of that conversation could kind of delve into marketing. So if a beneficiary says, asking some general questions and says, oh, how much is it for, what's the copay for seeing a specialist? The person at the educational event, in answering that question, would be able to answer that. Now, if they were just out there kind of spouting that from the podium, that would be considered marketing. But when it's answering questions, that would be allowed. The third bullet point is that plan representatives may set up future marketing appointments at educational events. And finally, that they may distribute business cards and other forms of contact information. As I mentioned, the distribution of marketing materials is still not allowed at educational events, and plans may not have marketing events immediately after educational events. So common questions. Seems like we had a couple problems with bullets this year when it came to releasing the MCMG. So we had two others that I would say this was probably in the top 5 of people pointing it out to us, and we appreciate it. These 2 bullets, bullet number 3 and bullet number 5 under section 50.2, we failed to kind of say that these things are prohibited activities. So in the update that I mentioned, health screenings, we say that they're not allowed, like cherry picking is not allowed, as well as the 5th bullet where we talk about using raffle information from the beneficiary based on a raffle. That's only allowed for calling the beneficiary to say they won a gift or didn't win a gift. And those 2, I believe, are in the MMG. So hopefully we didn't throw people off too much with that. 50.1, 2 questions for that, and that again is educational events. What does CMS mean by immediately following an educational event? And again, this is one where I think it's better to say what we're trying to guard against rather than saying a defined time. So it doesn't really, in my opinion, make sense to say, well, exactly 7 hours after an educational event, you can have a marketing event. That doesn't seem to fit. So what we're trying to guard against is a bait and switch tactic. So that organization may heavily advertise an educational event only to get beneficiaries through the door and to say, well, in the room next door, we can talk a lot more about, benefits and all this other stuff. And that is what we don't want. We don't want there to be this bait and switch kind of tactic going on when it comes to, positioning something as educational only as a means of getting into the marketing. I would say the bar now, especially because we do not collect marketing events anymore in HPMS, is pretty low as far as having a marketing event. I would argue that it's as easy as having an educational event. So if you want to share marketing, and if you want to talk more about marketing, and if you want to have a sales presentation, you're certainly clear to do so. Just do it as a sales event and not as a marketing event. And then 50.1, another question about these events. Can scope of appointments be collected and provided and collected at educational events? And I apologize to the folks that put together this conference. I didn't do this as a survey, but I would be curious in a raise of hands, how many people think that that would be allowed? And how many people think that would not be allowed? Okay, it would be allowed. We do allow scope of appointments to be provided and collected at educational events for future sales meetings. And again, keeping in mind that they can't be immediately following the educational event. I should have highlighted this in red because we clearly state that in the updated MCMG that's been posted. So you'll see in there that it's clear that scope of appointments can be collected at educational events. So now, digging a little deeper, is everybody feeling good and staying with me so far? That's good. I know an hour and a half of marketing and communications first thing in the morning is not exactly Starbucks. So we appreciate everybody hanging in there, and hopefully you find this very helpful. Activities in the healthcare setting, many familiar requirements in this section. Provider affiliation announcements, no marketing in the healthcare setting, which is a statutory requirement. Plans are responsible for the oversight of providers, and providers may not accept or collect scope of appointment forms. They may not persuade a patient based on financial interest. They may not be compensated for marketing or enrollment activities, and they may not offer other inducements for enrollment. A major change to this section is 60.1, which is provider-initiated activities. This is something that was traditionally missing from the MMG, and when I was working on the regulation, I began thinking of this section immediately when I was looking at public comments. We received a number of public comments from the provider community, and it became painfully apparent to me that providers felt, and again, based on the old definition of marketing, that they didn't feel comfortable speaking to their patients as a doctor in an exam room when it came to Medicare Advantage and some of the benefits of Medicare Advantage. And this is the last thing we would want to happen. So we set out and we created this section for those activities that a provider's doing not on the plan's request, but really on their own as a provider. So we say in answering beneficiary questions as well as a matter of course of treatment. And what this does is it allows additional flexibility for those interactions and providers to discuss things that would traditionally be considered marketing. But again, when you think of the intent and content, the intent is the treatment of the patient. It's not to get a patient to enroll into a certain plan or to benefit the provider or anything like that. And so in this context, like I said, providers can talk about cost sharing. They can talk about benefit structure. And a good way to describe this would be an example. So if a provider is meeting with a patient and that patient was just diagnosed with COPD, that provider feeling at ease in telling that patient, that Plan X offers a chronic condition SNP special needs plan, and this may be something that you want to look into because they specifically focus on COPD and this may be beneficial to your care. Those are the sorts of conversations that we never intended the marketing guidelines to preclude, and in section 60.1 we think that it does a much more clear job of letting providers know that that can take place. And of course providers Outside of that, can distribute CMS-produced materials as long as they're not altered. So if they want to download something from Plan Finder or something like that in counseling with a patient, that's certainly allowed as well. 60.2, this is more familiar, but because of the changes in definitions, we have some changes with it. So that's plan-initiated provider activities. So these are activities that a provider does at the request of the plan, their contracted plan or plans. Communication materials may be offered in the healthcare setting. So the prohibition is for marketing materials. Communication is not marketing. So those sorts of materials can be provided in the healthcare setting, as well as any sort of verbal communication that would fall under the guise of communications. Similarly, under 60.4, plan activities in the healthcare setting. The first bullet here in red is one that we've received a number of questions about, and in the updated version of the MCMG, we say that waiting rooms are now considered common areas, and we spell that out. In addition to that, communication materials similar to what providers can do, plans can do the same, can be distributed, displayed in the healthcare setting, and then in common areas including waiting rooms, marketing is allowed to take place. We also created 60.4.1, which was special guidance for institutional SNPs in the long-term care settings. And I-SNPs are a very complex kind of organization when you think about it. Depending on how you look at an I-SNP, they could be a facility, they could be a plan, they could be a provider. All of that under that kind of I-SNP umbrella. And so, first and foremost, those operating I-SNPs need to be very careful and put the appropriate boundaries in place between sales staff and clinical staff. That being said, we do allow for those working in a social worker capacity to provide materials to the residents. And when you think of those in a long-term care setting, it's very common to be confined to your room, that you don't really get out to a common area much. And so we wanted it to be, we didn't want to penalize somebody for their health status that they're unable to get certain materials. So we said that social workers are able to provide marketing materials, with the caveat being that those marketing materials may not include a scope of appointment and may not include enrollment forms. And the thought of this is trying to create this balance in this environment. We wanted them to have access to the materials. However, what I like to think of as the first step towards enrollment needs to be made by the beneficiary or their caregiver. So they're provided the marketing materials, they can look through them, review them, but when it comes to actually making a decision, I want to enroll, or I want someone to come and talk to me in more detail about this, a salesperson may be coming to visit in their room, we wanted that to be based on the beneficiary's action, not the action of a social worker. So I think that kind of creates a good balance and something that we'll be paying close attention to. So common questions for Section 60. The first here is a bit of a mouthful, and I'll sum it up by saying, if a provider is persuading a beneficiary to make an enrollment decision based on their own personal gain, would that be considered plan-initiated? And this is if there was ever a complex question, this is it. So first and foremost, I want to say that as a plan and as your contracted provider, there is an oversight responsibility there. On many levels, we look at that provider as being an extension of you, again, based on what activities they're conducting. However, I will say, with that being said, that if this came to our attention, this is something that we would look at communicating with the plan or touching base with the plan. I would say not necessarily with an immediate eye towards compliance, but more an eye toward having the plan conduct a review of what that provider's doing, do an investigation, and then report back to us on what they found and what appropriate actions were taken. So I would say, I don't know that it neatly fits into provider-initiated, plan-initiated. It's kind of none of the above, because that activity in of itself is totally not allowed. I mean, that's not allowed no matter who's initiating it. A provider's not allowed to do that on their own accord. They're not allowed to do that on behalf of a plan. So it's something that we would look at. But like I said, I think if it's the one-off sort of complaint, our eye wouldn't necessarily be directly towards compliance. It would more be to just trying to make sure that this activity is not taking place. And then 60.4, we talked about, or I discussed the fact that common areas are now waiting rooms. And we've received a question that if that's the case, what would common areas look like in the pharmacy setting? And when it comes to like a traditional provider office, their offices are so very nice and neatly segmented. You have the waiting room, you have the exam room, you have a room where they may read x-rays or other charts and things like that. The pharmacy, to use something from like HSTV, it's open concept, right? So the pharmacy kind of has, there's the counter, everything's just kind of wide and open. So you want to be wary, and each pharmacy is a little different too, which makes it a little more difficult. So you want to be wary in how you approach the common area of a pharmacy. Having said that, I would say that the immediate area of a pharmacy counter would be considered the healthcare setting. It would not be considered a common area, as well as any area that a pharmacy has to specifically counsel with beneficiaries, so maybe a little table off to the side or something like that. I would say that if there are chairs kind of off and away from the pharmacy counter, that would be considered a common area. So you have to use a little judgment there, just because pharmacies tend to be a little different, even among the big box stores. If you've gone to several, they're all a little different in the way that they're laid out. So with that, I'm going to turn it over to Christine, who's going to finish things out, starting with section 70. And you've made it at CMS when you have a step with your name on it. I just want to say that as we...
And hopefully that's a little bit better. Good morning to everyone. It's great to see everyone here, and it's good to have everyone on Webcast. I'm going to talk as soon as I get some screens. Okay, excellent. I'm going to start with section 70, going into websites and social electronic media. Familiar requirements. And we've lost it again. Okay. We have a lot of familiar requirements. The must and the may nots under the old MMG are pretty much still applicable. General requirements of your website, it needs to be easily understood. It needs to be clear, concise, so beneficiaries can read it. You need to maintain your current website through December 31st of the contract year. If you have two contract year 2018 and contract year 2019 going on at the same time, you need to be very clear on which documents pertain to 2019 and which ones pertain to 2018. And did that get goofed up by me bringing this thing up, down? Because we keep losing it. Okay. Another one of the requirements on websites, which you should be aware about, is you need to make it very clear when you're leaving the plan website so the beneficiaries know that they're leaving the Reinhard Healthcare website and moving on to a different type of website. You may not, as always, you may not have links to foreign drug sales. You are responsible for the contents of your website, and you're also responsible for the downstream entities. So if you have a PBM and you move the beneficiary from your website to the PBM, you cannot have a pop-up that says we are no longer responsible for the contents of the PBM site. And when you ask for information from beneficiaries to take a look at things like maybe a provider directory or a pharmacy directory, you are limited on the information that you can ask. You can ask for your zip code, your county, your state, but you cannot ask for specific identifying information from the beneficiaries. Required content, that's pretty much all the same. We need to have the ANOC up there, the EOC up there, summary of benefits, your directories, and that is all laid out in our website area, the documents that you need to have up there for beneficiaries. Searchable directories and formularies, that has not changed either. You need to have a searchable directory. Either it needs to be an online search engine or it needs to be a downloadable directory that can also be searched. So those things are pretty much the same as they have been from the previous MMG. New guidance. We recently, from the first release of the MICMUG to the release that just got done today, we've made some changes, and we sent out an HPMS memo on August 10th that outlined those changes. Any website that has marketing in it must be submitted. So if you've got a website that is only communications, you do not need to submit that website. Websites with marketing content are now file and use. And we made that because we realized that websites are most likely going to contain communications and marketing. So we don't want to hold up the communications piece because the marketing piece is under a certain type of review time frame. And again, if a website only has communications, you do not need to submit it to CMS. So, common questions, and we're there already. If a website only has CMS required content and no marketing content, does it need to be submitted? And the answer is no. Strictly communication content does not need to be submitted to CMS. CMS also says posted by October 15th. Can plans post information earlier? Yes, you can. Those are the deadlines for when we need the information up. Now, some of the pieces cannot be posted earlier than a certain date, and those are outlined in section 100.4. And again, if you have marketing, that cannot go up until October 1st on your website. Okay, moving on to call center, section 80. Again, we've got a lot of familiar requirements in the call center section. General call center requirements, you need to have interpreter services, you need to have TTY services. Informational scripts, those have pretty much stayed the same. We have provided specified topics that you need to be prepared to speak about. Informational scripts are aimed to provide answers to beneficiary questions and educate beneficiaries on certain aspects of your health plan. Marketing scripts, those do need to be submitted into HPMS because they are marketing. Now, as a note, we do not require that the marketing scripts or sales scripts be submitted verbatim. You can submit bulleted points on what your marketing sales scripts are going to cover. So we realize that these scripts, they're telephone calls. They're interactive phone calls between a prospective beneficiary or a current beneficiary looking at whether or not they're going to stay in the plan and your plan. So it's not going to be something that's just read straight from a script. They're interactive phone calls. Pharmacy help desk center requirements. Again, those requirements are pretty much the same. You need to be able to respond to pharmacy and provider questions regarding the formularies, cost sharing. The operating hours need to be during the network pharmacy operating hours. So if you have network pharmacies that are open 24 hours a day, you also need to ensure that that pharmacy help desk is open 24 hours a day. And okay. We have 90 minutes. I'm okay with burning 30 seconds here or there. So I feel like I should ask some questions to get input. How many people have come from out of state? Excellent. Anybody from the West Coast? Hawaii? Oh, we got someone from Hawaii. Wonderful. Mountain time. I'm desperate. No one from Mountain time? Really? Okay, one. Central. Okay. Alaska. Okay, I figured that one was no, but I was surprised with Hawaii. Okay, they're trying to figure it out, but we're not having a whole heck of a lot, so you're just going to need to, I think a lot of you have the slides in front of you, so I'm just going to go ahead and talk. And thank goodness I printed them out, because I'd be asking someone for their copy, which would be embarrassing. Okay, going into the call center hours of operation. That section is really pretty much the same as it was, except for the OEP. We are now requiring that live CSRs be available 7 days a week, 8 a.m. to 8 p.m., alternative technologies on Thanksgiving and Christmas from October 1 through March 31st. So previously it was only during the AEP, and we've extended that through March 31st for the OEP. From April 1st through September 30th, we go back to the non-OEP AEP time frame, and you have to have live CSRs available Monday through Friday, 8 a.m. to 8 p.m., alternative technologies, Saturday, Sunday, and federal holidays. So let's talk a little bit about activities in Section 80.7 that do not require a licensed agent. Now, I do want to put a caveat in here. Different states have different laws and regulations on what licensed agents are permitted to do and are not permitted to do. You do need to pay attention to those particular states. If their laws are more restrictive than ours, obviously you pay attention to those because states are the ones licensing the agents. But we generally do allow licensed agents to be customer service agents. They cannot act simultaneously as an agent doing marketing and sales and a customer service agent simply answering beneficiary questions. So if a beneficiary calls up and starts asking, what's my current premium for the plan, and the agent says, oh, it's $35 a month. And the beneficiary says, oh, I thought you had a plan that was $0 a month. The agent can move from a customer service agent into a marketing agent, but then they need to make sure that they need to be very clear that their role is changing, because that telephone call has gone from a educational call, the beneficiary asking information about their current plan, to a marketing call where they're inquiring about different plans because they may choose to enroll in a different product the organization offers. So that can be kind of tough. Please provide a lot of information and education and training to your sales agents so they are aware of scenarios where it could move from a non-sales call, regular customer service call, into a sales call. Yes. Uh-huh. Well, it's really, I mean, it's going to depend upon state law for what agents can do. Under planned business, if they're a current beneficiary, a current enrollee in one of your other products, you can certainly, under our general rules of planned business, talk to them about the other products. I would also encourage you to look at the state-specific MMP marketing guidance. I am not an expert on that because there are variances between different states for that guidance. So generally I would like to say yes, but it really is going to depend upon specifics on state law and MMP guidance. So we had a couple of common questions. First, do the days, hours of operation also apply to downstream entities? Yes, they do. So if you're outsourcing your customer service center, the customer service center that's your downstream entity, it needs to adhere to hours and days of operation that we set in the MCMG. Do the days and hours of operation apply to sales lines? No, they do not. We do not require that plans market. We do not require that they have a sales line open, so those operation and days and hours of operations are not applicable to these types of lines. Moving on to Section 90, Tracking, Submission, and Review Process. So there's a lot of familiar requirements. The time periods for marketing materials, again, it's 45 days for the marketing materials. The HPMS submission process is generally the same. You're going to log into HPMS, you're going to go to the marketing module, you're going to upload your documents. All of that has remained the same. The multi-submission process, that process has remained the same. We tried to streamline that process a little bit more in the MCMG. I hope it's a little cleaner and clearer exactly how the multi-plan submission process works with your lead region, your non-lead region, your coordinating entity. So please take a look at that if you do have multi-plan submissions and read that section on how to upload those materials. Model materials, as you should be aware, we've got standardized and non-standardized model materials. Those definitions are the same. Standardized are the ones that you are not permitted to make changes unless specified by CMS, and Two of the models that come to mind are the ANOC and the EOC. The non-standardized models, again, we've got different time frames. If you use the model without modification, you've got one time frame. If you do use the model but you modify it, it's a different time frame. Directories are one example of the non-standardized model that you have to include all the requirements that we list, but you do not necessarily have to use the model as it is provided to you. Template materials, and this is an area that we also tried to make a little bit more clear in the MCMG. There's static templates and there's standard templates. Static templates have to be submitted, but when you fill out those templates, they do not need to be resubmitted. But there are specific key variables in a static template. Those are things like plan names, phone numbers, event days, event times. Standard templates, you submit the template into HPMS. When you populate it, those do need to be submitted. And the key difference between the static and the standard is the standard is going to have cost-sharing benefit information. So that is information we want submitted, because when you have a template that you're using for possibly 4 different PBPs in 4 different areas, we want to ensure that the cost-sharing and benefit information is accurate for each of those PBPs and service areas. Things that did change on the material ID. As Jeremy mentioned, we have these 2 buckets. We've got the communications bucket, and we also have the marketing bucket. We have a new material ID methodology. Hopefully, it's a little bit easier. We are requesting your H number. It could be your MCE number. That goes first by an underscore. And then you have the plan designated alphanumeric number. You can name that whatever you want to, ANOC 2018, ANOC 2019, and then an underscore, and you're going to simply have one letter at the end. It's either going to be M for a marketing material or C for a communications material. So it's a little bit shorter. Please note we are not requiring pending, approved, file, and use. That information no longer needs to be on the material ID for your documents. Web pages, they do not require a C or an M because, as I stated before, many times those pages contain both marketing and communications, so there's no ending for those web pages. Agent-developed communications, those don't actually need to be submitted because they are communication materials, so the agent does not need a material ID on that. Materials subject to submission. All marketing materials require submission. So going back to the content and the intent, if your document meets both content and intent, you need to submit it to HPMS. Communication materials that are designated by CMS require submission. Right now we have the EOC listed as one communication material that does require submission. We may in the future add additional documents to that list that require submission, but generally most of the communications do not require submission into HPMS. But again, you still have to have a material ID on that document. And as a note, the regulatory changes took effect in June. Our MCMG came out in July. HPMS being a system, it does take time to develop business requirements and get those implemented. So we are still working on HPMS. I want to say catching up to our new policy. So there will be changes in the next version of HPMS and in future versions. So some of it might not be as clear as it could be, but we're working on that. Now, we did implement a new HPMS functionality, and that's a material replacement. What it allows for is updates of existing materials without having to resubmit them under new material IDs. And let me use an ANOC as a wonderful example. You ship out your ANOC by September 30th for your beneficiaries. On October 5th, you realize, oh my goodness, I made an error in the cost sharing of PCP visits. It's not $15, it's $10. You, as normally, would submit an errata sheet into HPMS, but you're also going to be submitting a replacement document. You are going to be attaching The replacement ANOC, which now has the correct $10 instead of $15, you're going to wind up attaching it to the original ANOC. So when we here at CMS take a look at the history of your ANOC, we'll see that one was submitted on, just say, September 20th, and then a new one was submitted, say, October 10th, and we'll be able to see version 1 and version 2. That way, CMS is going to be able to always find the most recent, accurate version of your document. It's really going to help us out a lot, and we hope that it's easier for you for submissions. The HPMS user guide goes into detail on exactly how to do that. So really, I urge you to take a look at the user's guide to find out the technical aspects of replacement materials. Right now, that replacement material functionality is only applicable to a certain number of documents, and that's the ANOC, the EOC, the SB, star rating documents, sales scripts and presentations, and enrollment scripts. So again, if you have changes to any of those, do not submit a new material with a new material ID. Please use the replacement functionality. I think it'll really help you keep a better management and tracking of your documents in HPMS also. Okay, non-English and alternative format materials. We made some changes to this also. Normally, previously, we required the non-English versions be submitted into HPMS. We are no longer requiring non-English versions be submitted into HPMS in pretty much all cases. So when you have your EOC and you've submitted that into HPMS as with the _C for communications, when you've translated that for a population in Spanish, Chinese, whatever language you have translated in, we do not require that those translations be submitted to HPMS. Materials that are multi-language do need to be submitted into HPMS. So if you have a document that is English on one side and Spanish on the other, it does need to be submitted. You do need to include multilingual in the comment field. There's also one other type of document that, although it's a document that is developed in a different language, so for instance, your service area is Puerto Rico, you're probably developing a lot of your documents, your marketing materials in Spanish for that market. We do not require the Spanish version be uploaded. We actually require an English version, the English translated version be submitted into HPMS so we can review and ensure that everything's correct in that document. Websites, again, they're file and use. The initial submission is just going to be the URL. Since we no longer have this pending concept and a review of the website while it's pending, it's file and use, submit the URL. When you make changes to the website, you're going to update the URL and you're going to provide HPMS an outline of the changes. So that's very much a streamlined approach to websites. We're hoping that you do appreciate that and it's a little bit easier for your organization. And there are two different codes when dealing with websites. There's the 4006 code, which is probably the code you're going to use the majority of the time. That's for the required website. As you know, we require you to have a website. It requires certain pieces of information, which are all outlined in the MCMG. That should be submitted under 4006. If by some chance you have a different website, if you have potentially a sales-only website, that would be submitted under code 4037, or if you contract with a third party that has a website dedicated to your product, again, that would be under 4037. Common questions. Do I have to change the material ID for previously submitted materials? No, you do not. We are requesting and requiring that you use the new material ID methodology moving forward. So when you retire a piece and you update a new piece, please submit it using the new material ID. Material ID, if it's not submitted into HPMS, does it still require a material ID? And that question we've gotten, and we also have gotten the question as to why. Yes, it still requires material ID. Many of your documents that you're going to develop are going to be communications documents. If we get a question about a communications document, or if we get a complaint about it, we need an easy way to tell your organization, we are looking at this particular document. The easiest way for us to know which document it is and for you to find that document is a unique material ID on that document. So instead of saying, I'm looking for this particular, let's just say, pharmacy directory in this particular service area. It's easier to say H123 for pharmacy directory 023_C. So it's going to save a lot of time and effort when we need to look at communications documents. And as Jeremy had mentioned, if we need to look at them, we will request them from your organization, either directly or through your account manager. Will certain types of materials still be designated as non-marketing? If so, does this impact the last part of the material ID? And again, that answer is no. The last part of the material ID is always going to be your C or your M. The concept of non-marketing is an HPMS concept, and as I mentioned before, we're working on getting some of the HPMS systems issues to catch up with some of our policy changes. Section 100, required materials. Familiar topics, familiar requirements, mailings to multiple beneficiaries in a household. Again, you need to ensure that those beneficiaries are related. That could be the same last name, the same address, the same apartment number. You may not mail one document to multiple beneficiaries in common housing. So for instance, an assisted living facility or a skilled nursing facility. Even though they might have different room numbers, those you're not permitted to have the same mailing go to multiple people in those areas. Changes and corrections to existing documents, that process is the same. You would submit corrections. ANOC and EOCs are used via the errata process, and the yearly HPMS memo dealing with the erratas and ANOCs and EOCs should be coming out relatively soon to go over that. And required materials. Again, we have certain required materials that need to be sent to beneficiaries. We've got timelines, and those are all listed in section 100.4. An area that we did change is electronic delivery of materials. This, we received a lot of questions on this, and there was some confusion. So I'm going to try to make it, we've tried to make it a little bit more clear in the MICMOG, and I'm going to try to clarify what we mean by the two different processes. We've got one process which is the notification of availability of electronic materials. That's a mouthful to say. That really applies. Okay, then I'm jumping ahead of myself on the slides. And then we have the electronic delivery of required documents. We're going to take a look at them each individually. The first one, the notification of availability of electronic documents. The title really says that. That is not sending the document electronically. That is notifying the beneficiary that there is an electronic version of that document available. This process does not require beneficiary approval. Okay, there are limited documents for which we are allowing this to occur, and that's the EOC, provider pharmacy directory, and formularies. What this essentially is the plan sending the beneficiary a letter saying, "Dear beneficiary, instead of mailing you a very voluminous EOC or provider pharmacy directory and formulary, which is huge, obviously not using those words, we are making those documents available to you on our website at www.reinhardthealth.com/EOC or /required documents. If you would like a hard copy of those documents, you can call us at 1-800 health plan, and you may request a hard copy and we will mail it to you. So it's telling a beneficiary where they can access it, how they can get a hard copy. We believe that this is really beneficial to both plans and beneficiaries because that's a lot of paper that is being produced and a lot of paper that is being sent to beneficiaries when many times they're looking, especially with provider directories, they're looking for a specific provider. They do not need to have the entire directory at their hands because it's really pinpointed. The notice. When you send this notice, you can send the notice with your ANOC when you send that out. You need to include the website address that you can access the materials. You must include the date the materials are available. And in section 100.4, we outline those dates. You also must provide a phone number to request hard copies. If you'd also like to provide other ways to get the a hard copy, such as an email, you may certainly put an email address in that beneficiaries can use to request hard copies. One notice may be used for multiple materials. So you can put the EOC, the pharmacy provider directory, and the formulary all in one notice. Again, make sure if you have specific websites for each of them, you're very clear on how to access each of them. You might just have a landing page that has links to all of those. That would be fine also. Notices do need to be sent in time for the AEP, and we certainly encourage but not require that those notices be mailed with the ANOC. And again, if an enrollee requests a hard copy, you must provide a hard copy, and we have stated in the new MCMG that that needs to be provided within 3 days of the request. And given that weekends occur, we're looking at 3 business days for that. Now, the second type of electronic delivery. This requires prior beneficiary approval, and this is the electronic delivery that your organizations are used to. The beneficiary calls up and has said, I am so tired of getting all this paper, can't you just send it to me electronically? So they opt into a process. It's a much broader range of materials. Any of the required materials can be sent to the beneficiary electronically. And in this particular case, when the beneficiary is opted in, there are some specific requirements. You need to specify what type of format. It might be a CD, it might be just email, it might be different, it might be a USB port. You also need to provide an opt-out mechanism. So a beneficiary that has opted in for this electronic media 2 years ago and they now want to receive everything hard copy, you need to have an opt-out process so they can get a hard copy. You also need to provide hard copies upon request using the 3-day rule. So when we go with the electronic delivery of required materials, when you send the electronic, say you send it through email, this document with a link to exactly their EOC or their information. If the email address or the method of sending it is no longer working, you need to send a hard copy. So you get a bounce back on the email, you need to then send a hard copy. The delivery date is when the email is sent. It is not when the beneficiary opened the email, it is when your organization has sent it. And then if your plan encounters an invalid email, such as a bounce back, you have to hard copy, send the document, but the date of delivery is when the email was originally sent, not when the hard copy is sent or received. Did I go? Okay. Then moving on to the list of required materials in 100.4. This is a new section which we hope really makes a lot of sense to your organizations. Previously in the MMG, we had the required documents spread throughout the MMG. We took them all out of the specific sections and we consolidated them into section 100.4 of the MCMG. That section provides what the document is. It clearly states whether it's a communications document or a marketing document. It tells who it needs to go to and when they need to receive it, whether it's prior to enrollment, whether it's annually, when it needs to be sent. For instance, the ANOC needs to be received by September 30th of each year. The delivery method, whether it's hard copy or whether the notification could be used. The format, the guidance information, HPMS information. So that is your cheat sheet for required documents on exactly what needs to be done with those. So we think that that's a huge improvement on making it a lot easier to read. The font size. Required documents must be in 12-point font. Your marketing materials do not need to be in 12-point font. If you want to put them in 2-point font, you're welcome to. I'm not sure who can read that, but go for it. Common questions. The original release on July 20th provided a date of 9/24 in section 100.2.1, and that was the notification of availability of electronic materials. We have modified that. That date is now September 1st, so you have a lot more time to get, you can send that out a lot earlier than before. 100.2.1 also had a sentence that said Part D sponsors may send existing, not new enrollees. We have changed that. We meant prospective enrollees in that. 100.2.1, is there any flexibility for the provision that requires hard copy requests to remain until the enrollee leaves the plan or requests that hard copies be discontinued? Okay, so the beneficiary got the availability of electronic communications, and they call up and say, I want a hard copy of my EOC. We have made adjustments in the MCMG that will allow you to say to the beneficiary, is this a one-time request, or do you want us to send you hard copies permanently? So it could just be a one-time request, especially maybe it's the provider directory. That might be a one-time request. We are not going to require you to send it every year if the beneficiary doesn't want you to. You just need to inquire and get that information. 100.4, what does CMS by not applicable or not required under HPMS timing and submission? It was the use of two different words meaning the same thing. It's not required. If a model is not required, I think that's where it was with model, not applicable or not required. We changed it all so it's the same language in the MCMG. If I modify a model material, do I have to submit it for review? Again, if it's a communications material, no. If it's a marketing material, yes, it would need to be submitted, but I'm not sure offhand. I can't think of marketing materials that we have as models right now. Agent broker activities, oversight, and compensation requirements. There's a lot of familiar requirements, agent requirements, plan oversight requirements. Agents need to be licensed, plans need to ensure licensure, trained, tested annually, passing the test at 85%. So those are the requirements that are pretty much the same. Compensation has not changed. It is the same as it has been for a couple of years now. You may not pay initials more than FMV, renewals up to 50% of the FMV. Substantively, that hasn't changed. The agent broker section has been streamlined. It has, I believe it's easier to read. So the look and format has changed, but substance hasn't when it deals with requirements and compensation and rapid disenrollment. There is some new guidance in the agent broker compensation area. We've gotten a lot of questions on agents wanting to use CMS created materials. I want to download the Medicare plan finder information for these plans. Previously, that is actually considered to be marketing because the intent is to sell the plan, and the content includes cost-sharing benefits. We're allowing agents to use CMS-created materials without submitting them, provided there are no alterations. They may not print out Medicare and You, the Medicare.gov plan finder information, and start picking and choosing which benefits they want to put on another document and saying it came from Medicare.gov. They have to use it exactly as it is on the website. But if they want to print it out and compare one plan product to another plan product, they're able to do that. Agents As Jeremy mentioned earlier, may provide business cards at educational events. They also may receive scope of appointments at educational events. They also may create and distribute communication materials without a material ID. Now, remember that communication materials are not submitted to HPMS. Agents, we're allowing them to create those communication materials without submitting them to HPMS either. An important note, these are our requirements. Plans are always able to and welcome to impose stricter requirements on their agents via their contracts. So if you do not want your agents producing communication materials without you looking at them and reviewing them, put it in your contracts. Just don't let them do that. You can make the requirements stronger, more strict than our requirements. Common questions. Are there typos in the rapid disenrollment section? Yes, there were, and we corrected those in the new MCMG that has since been released. Beneficiary referrals. Our compensation covers the compensation of independent agents, and it also goes into employed agents and captive agents, the requirements. We do not regulate beneficiary referrals. Use of Medicare beneficiary information obtained from CMS. This was Section 160 of the MMG. It's been consolidated. The core requirements are exactly the same. You need to make sure you've got a data use agreement in place. Outside the data use agreement, if you're going to use information, you need to have a pre-existing relationship that allows for the additional flexibility. Non-health related mailings do require consent. So again, the information is the same, it's just shortened a bit. Disclaimers. We made some changes to disclaimers. We have a lot fewer disclaimers, as you probably have seen in the disclaimer section. They've been streamlined. We've done, over the past few years, we've done a good amount of consumer testing. We've tried to make them clearer for beneficiaries, more understandable, better comprehension. And we have information for applicable material types, marketing, communications. So there are disclaimers that are required on certain types of documents. So do pay attention to that appendix to take a look at the specific disclaimers. Exempt materials. The federal contracting disclaimer is required under all the materials unless it's specifically exempt from the disclaimers. So I think there were some changes in the new MCMG dealing with that. Common questions. Are there any other disclaimers that were previously in the MMG? No. If it's not in the disclaimer section of the MCMG, it's no longer a required disclaimer on your documents. Can we use existing stock for envelopes? Absolutely, you can. And when it comes to envelopes, we have now in there that you need to submit, you need to have the plan name in that on the envelope. And what we mean by that is we mean a name that the beneficiary will recognize. So if I have, everyone knows me by Reinhard Health. If I've got Plan Gold, Plan Silver, and Plan Platinum, if I don't want to print each envelope with gold, silver, or platinum, I can simply say Reinhard Health, and the beneficiary will recognize, oh, I'm in Reinhard Health Platinum Plan. So you can use that. The envelope, it also, if the name is visible through a window, it does not need to be listed on the envelope. It just needs to be seen by the beneficiary prior to opening it. Pre-enrollment checklist. Jeremy and I made a deal. If he used the acronym MCMG, I would use our acronym for the pre-enrollment checklist. And we are affectionately calling this the PICL, P-E-C-L. So, MCMG and pickles. This is brand new. And this was part of trying to decrease the number of disclaimers. We realized through consumer testing that beneficiaries were looking at a paragraph of disclaimers on a lot of the information they were looking at. And so much of that, although the disclaimers were important, and very important in some cases, they weren't really paying attention to it. So we came up with this concept of what are the really important things that beneficiaries need to know before they sign on the dotted line. And that is where we came up with the PICL. It's a pre-enrollment checklist of important pieces of information that the beneficiary must know. For instance, if you go to an out-of-network provider, it might not be covered. They do not have to agree to see you, and you might not have benefits paid for you. There are a list of that on the checklist, so please take a look at those. The questions we've gotten dealing with the PICL is, can I alter the checklist? Generally speaking, no. On the checklist, there are some instructions on things that you may do. The language of each of those items on the checklist may not be changed. However, if your organization is using a singular checklist for multiple types of plans, we are allowing you to add an additional sentence after some of those items for applicability reasons. For instance, there is, and I'm paraphrasing, there is a bullet there that says, out-of-network providers may not be covered and you'll have to pay the full price. If that checklist is being used for an HMO and a PPO, you may put in an additional sentence, please note this does not apply to PPOs. And again, you can use whatever wording you want for that sentence to make it clear when something is not necessarily applicable for that. Does the checklist need to be completed or handed in with an application? No, it does not. If your organization wants to have those checklists handed in, you certainly can require that to be done. What about online enrollments? For online enrollments, you need to have some sort of a link that will direct the beneficiary to that checklist that they can click on to see the important notes that they need to know about the plan prior to signing up. Telephonic enrollments. Similar to online enrollments, you need to inform the beneficiary that there are important pieces of information that they really need to know prior to enrolling the plan. Best practice would be to go through those items on the checklist with the beneficiary so they really understand the plan rules. Can employer groups be exempt from using the PICL? Yes, they are exempt from the use of the PICL. So we've got a few other MCMG sections. Appendix 1, definitions. There's really minor updates to account for new definitions of marketing communications. Appendix 4, external links. Previously, we had all the external links added all over the MMG. We have consolidated them into one spot in an appendix. Appendix 5, summary of benefit instructions. Minor updates between last year and this year. It's basically the same. Employer union group health plans, formerly Section 130 of the MMG. There are no substantive changes to that section. Appendix 7, use of the Medicare mark for Part D sponsors. That was formerly Section 150, and again, no substantive changes for that. Looking forward, the MCMG. We're currently, as I mentioned earlier, updating HPMS. Submission codes are being updated. As we realize there are items that need to be fixed or corrected, we're correcting, fixing, modifying as soon as we can, when we can. We will continue to do retrospective reviews to monitor you for compliance with existing requirements, compliance with new requirements. We're going to have a couple of different reviews. We'll have the proactive reviews where we just decide to review, say, summary of benefits like we've been doing for a few years now, where we pick a sample and review SB from every single organization. We also might have reactive reviews, and that could be a review based upon complaints coming in from beneficiaries, complaints from SHIPs or other consumer advocacy groups. We could do a small-scale reactive review on a plan or a service area, or a much longer review. Reviews, retrospective reviews, may include both marketing and communications material. So if we are reviewing something that we've heard issues about in its communications material, we may ask you to submit that information into HPMS. Now, there's one last thing we did have on our presentation, which we do need to talk about for just a minute, provider directories. And I've left 6 minutes, and I'm not going to quite take that time up. We have just finished our third round of provider director reviews, online directories, to gauge the accuracy of those reviews. This has been a 3-year project. following the reviews, the results this year are pretty much on par with the results for the first 2 years. We're looking at about a 45, 46% inaccuracy rate. Hasn't gotten any better. We've got fluctuations from organizations that have had as low as 2% inaccuracy rate, which is unbelievably great. And we've had plans that are up in the 90 percentile for accuracy, which has a lot of room for improvement. It is still a really important part that we're looking at. We're going to continue to look at online provider directories. We encourage you, expect you, want you to continue reviewing your directories and making improvements in those directories, because it is a beneficiary tool that they use to help locate healthcare when they need it. And we have 2 contacts, well, actually 3 contacts, myself or Jeremy, but general questions really do need to go to the marketing@cms.hhs mailbox. That way our appropriate subject matter expert will get that question, and then it will be answered to you in probably a more timely fashion than coming directly to Jeremy or I, because we'll get bombarded with questions. And we have 4 minutes, I think, for additional questions. We don't have time for additional questions. Oh, darn. Okay.
Thank you, Jeremy and Christine, for walking us through the various changes to the marketing and communication policy. Okay, it is now time for our first session evaluation. Please take out your phones if you would like to text your response, or go to Poll EV on your smartphone, tablet, or computer. If you would like to evaluate the session, and we encourage everyone to do so, and you're participating by your cell phone, go ahead and enter 8 in response to the question, "I would like to evaluate this session," and send your response. You will receive a text with the following message, "Hello," and "Please evaluate the session," followed by a link. Go ahead and select that link, and you will be taken to the Poll Everywhere site. Choose Start, and you will be presented with the evaluation questions one at a time. Select your answer and click Next to advance to each question. Submit your response by choosing Finish. If you are participating via the internet, when prompted by the moderator, go ahead and choose Yes in response to the question, "I would like to evaluate this session," and this link appears quickly at the top of the screen in green, and go ahead and click that link. Okay, our next session today, the CMS Chief Actuary will provide an overview of the Office of the Actuary, including the role of OACT within CMS, their various products, how they produce their work, and their expectations for Medicare Advantage and Part D actuaries. From the Office of the Actuary, please help me welcome Paul Spitalnik.
Good morning. I am the Chief Actuary. I've been asked to talk a little bit about what the role of the Office of the Actuary is within CMS. I know 2 things about the session I'm about to speak to. One is that it's the last session before lunch. And I also know that so many in this room have traveled a long distance, and those that are watching on the webcast have been waiting a while. to really learn more about the Office of the Actuary. And I understand and I hope that this will, I'm going to try to balance between those two, but let's get right into it. So the Office of the Actuary serves a particular role within CMS. We provide independent, objective, technical information both within CMS and to a number of constituencies within the administration, including our representatives at the Office of Management Budget. We have a relationship with those that are on Congress. We have direct relationship there that they can formally request us to perform some analysis, and we are obligated to do so. And so this is just a little structure about how the office is structured within the agency. There are 3 different groups. There are 2 actuarial groups. The first is the Medicare and Medicaid Cost Estimates Group. They do mostly fee-for-service related work, as well as for the Medicaid program. Those that are watching on this are probably most familiar with the work of the Parts C and D actuarial group. And they provide all the support for basically private plans. We also have a National Health Statistics Group. This is our predominantly economists and statisticians. And we'll talk a little bit about all the different things that we work on. Here's the main work that the office works on. Current law financial projections for Medicare and Medicaid and all of the programs that CMS is responsible for. Estimates of proposed legislation. Rate setting for both the Medicare and Medicaid programs, CMMI model and other certifications, NHE, National Health Expenditures, as well as what you're probably most familiar with, or many are most familiar with, review of bid submissions by MA and Part D plan sponsors. So some examples of current law financial projections. We work on trustees report, President's budget projections, statement of social insurance that's included in the CMS and government-wide financial statements, as well as an annual report on financial outlook for Medicaid. What typically gets the most attention from the work that the Office of the Actuary does is the work that we do in support of the Medicare trustees. Here's a couple of sample headlines that follow that work. Usually it's focused specifically on the date of depletion for the Hospital Insurance Trust Fund. There are 250 plus pages there. There's a lot more in the report than just the HI depletion date. And I believe many of your actuary colleagues actually find some of that information useful. So what's in the report? There's the formal evaluation of the status of the trust funds, projections under current law, and there's also some projections under some alternative assumptions as well as an illustrative alternative scenario. Doing the budget work, that's part of the annual process through the Office of Management Budget. Annually releases the President's budget, the 10-year projections for both the Medicare program, Medicaid program, some of the exchange expenditures, various pieces that CMS touches, which are obviously some pretty significant dollars. There's generally 2 cycles there. The budget cycle generally is released in the wintertime, right around the State of the Union typically. Mid-session review typically comes out 6 months thereafter roughly, and includes a mid-year update. Annually, we report on the financial status of the Medicaid program, including projections of enrollment, expenditures, as much detail as can be provided for the Medicaid program. On more of an ad hoc basis, we present estimates for various proposals to modify the various programs that CMS is responsible for. These can come from, as illustrated here, either within the administration at CMS, HHS, OMB. Sometimes we'll get a request from Congress, or even some national commissions will directly ask us to weigh in on what the financial coverage, other implications may be for some propose modifications to some of the proposals that, some of the programs that CMS works on. Sometimes these get reflected directly in the budget work. Sometimes we will separately release an analysis specific to a particular piece of legislation. Illustrated a few here that have gotten some attention over the last several years. The Affordable Care Act, MACRA. Last year, as part of the health reform, we provided some analysis there as well. Rate setting for the Medicare program is another important work that the Office of the Actuary takes part in. Annually, we advise the secretary, the administrator, and the secretary with respect to what the Medicare Part B premium ought to be, that therefore determines what the benefit parameters, so what the Part B premium, Part B deductible would be. Similarly, we estimate what the HI deductible and the various copays along that program should be. We also produce, this is one of the work of the NHSG, the statisticians and economists, update the price indices for how basically the payment rates for fee-for-service will be updated each year. And then annually, you may have been familiar that once a year we come out with a rate book that affects all Medicare Advantage payments. So the Part B premiums, that tends to get a fair amount of attention. That usually comes out in the fall. And we've just recently announced the Part D benchmark calculation, which determines what the various Part D premiums will be, and that'll be announced more specifically with respect to the Part D plans. Once that rollout is complete. The MA rate book and benchmark, I think most are pretty familiar with this. This is the county level benchmarks that are published annually in April each year. Represents the cost of providing care for an average 1.0 risk score beneficiary. There's separate rates for those with ESRD and non-ESRD. Importantly, these assumptions, the basis of the rate book calculations is generally consistent with what's included in the trustees report. Benchmarks, how it is applied to a specific plan, it's based on the specific makeup of that plan. Which counties are they operating in? What are the projected enrollments in those counties? So CMMI models, so there's lots of different models that are being tested each year. In order for a model to be expanded, two things need to happen. The secretary must determine that quality has improved or at least has not been negatively affected. And at the same time, the CMS chief actuary, that's me, needs to certify that either costs have not increased or that there has been a cost reduction. So if those two things happen, a model can be expanded. We have been able to certify 2 models to date, the Pioneer ACO and the diabetes prevention model. We hope to be able to certify and expand more models as they're deemed successful. There's some other, called miscellaneous certifications that every so often our friends in Congress say that we need a CMS chief actuary certification for things that aren't necessarily things that we directly work on, but things like essential health benefits or rates of uninsured, or 2 other items that I am required to certify to. Annually, we release national health expenditures. The 2 separate rollouts there. One is looking at the history, so analyzing what services have been delivered, who's been paying for those services, where did it come, where did it go. So one release is looking back at the history, and another release are looked at the projections for those various factors. If you happen to go into most any economic analysis or detailed study of a paper analyzing anything having to do with health expenditure, health care in the U.S., almost certainly they will cite in one way or another the works of the national health expenditures. It's basically considered by others, I tend to agree, the gold standard for understanding what the source of health spending is in the U.S. On less of a recurring basis, we go out with some more specific national health expenditure projection estimates. One is looking at age and gender. This is something that some of your actuaries might or others might find particularly interesting, and others looking at some state health expenditures. To what we expect to our work with MA and Part D plans. So each year, as you know, first Monday in June, bids come in. It is our role in the Office of the Actuary to take a look at those bids, make an evaluation, and to basically make a recommendation as to whether or not the standards have been met. Pretty much I've listed the key ones here. Have the bids been demonstrated to use appropriate use of data, reasonable care in developing assumptions, documentation requirements, et cetera. To the extent that we sign off, then everything goes pretty smoothly. We have not yet gotten to the point where, I'll say it this way, in every case where a bid has been approved, there has been the ability to get to contracting. The converse is not necessarily true. The last slide that I have, and I've made up some time here, so for those that were worried about lunch, I will accept your appreciation. The last slide I have is what are the key asks that we have for your actuaries? And so this is the one thing I wanted to kind of leave everybody with, and I know that there are some actuaries that are participating here. So basically it's just be familiar with what the expectations are. Be familiar with what the rules are. Things like today's conference are a good illustration of how CMS attempts in every way we can to be proactive in making sure that what the expectations are as clearly communicated as possible. So we expect that when we're going through the bids, that the bid, going through that bid process, that those that are participating in that process are familiar with that process, understand the bid instructions, understand the requirements around the call letter, understand the various requirements that have been put forth and have been communicated. Just in terms of general good actuarial work, make sure your work's been peer reviewed. I understand that shortly before bid submission, there's a degree of chaos that may be swirling around. There might be a lot of things happening at that point in time. It really does pay to pause for a moment to make sure that what's coming in on that first Monday in June is what everybody intends. To make sure that that the bids that have been prepared are really what you want to be standing behind. We've asked this every year. It has gotten to the point where this is hardly an issue, but it certainly bears repeating. Make sure that the supporting documentation is as clear and as well written and as could be well understood by others as possible. And again, this has been, the program has matured over time. The expectations have generally been realized, but be timely, be responsive. There's a lot that we ask of you. But if you turn it around basically in about a 6-week time period, we have to go through the various thousands of bids that have been submitted and generate an opinion on it. So we do ask and do expect that we get responsive and timely responses from your actuaries. I see I've made up my time. I have time to answer any questions for all of the burning, unanswered questions that you may have had about the Office of the Actuary and the various things that we do. I know I went through them fairly quick, but I certainly wanted to have the opportunity to answer any questions that anybody might have. I'm supposed to step back.
Okay, are there any questions for Paul? No? Okay, then at this time I would like to thank Paul for the overview of the Office of the Actuary. Thank you. right, so if you would like to evaluate this session, go ahead and take out your phones and enter A, or on your iPad, tablet, or computer, go ahead and enter A and follow the link and answer the questions. Just a couple reminders for you. We do have the photo backdrop that is out in the hallway. So if you'd like to do that, get out your camera and see one of our staff to help you out there. Videos for the fall will not be posted until they are approved. And once they are, you will receive a notice via email.